All right. So welcome, everyone. I would first like to thank the International Dental Implant Association, Dr. Garg and Brianna for having me here today. Um, it's really a pleasure, and in these very tumultuous times, I really appreciate that the IDIA is making the effort to provide some very good education. I know personally, I really learned a lot, and you had some really great topics and speakers here. So I'm just happy to be participating along. The topic I'm going to do today is on dental ceramics. Typically when we do this course, it's an all day, and we take it from material selection all the way to cementation. In the past week, the IDIA had some really fantastic lectures from Dr. David Hornbrook and Dr. Daniel Vasquez. And so a lot of the topics I tried to pick were twofold. One, I didn't really want to overlap too much with those great instructors had gone over already. And secondly, I wanted to choose some topics that were really probably the participants in our courses have the most concerns or questions about. So as a means for introduction, I do practice in Queens, New York. I am pretty much a native New Yorker, although I did do some, went to University of Miami. So as I was telling Brianna earlier, it's good to have some Miami people here, especially close to Aventura, which was the town that I lived in. But this practice that I'm in now is actually within walking distance of where I grew up, and actually still live quite close. So I'm very much a community dentist, and I'm happy to be there, and I really do love of Queens. I am a general dentist. I did do most of my schooling in New York, but about 2 years ago, I had the opportunity to partake in an undertaking that I really kind of had a strong desire for. And namely, that was to get more involved into CAD/CAM dentistry. Now, I was influenced by people like Dr. Vasquez, and you're going to hear from him, I believe, next week, and that's Dr. August de Oliveira. And they really inspired me, among other doctors who you would know, to kind of delve into the realm of CAD/CAM dental ceramics. And it was an opportunity, and it became a bit of an obsession. And luckily, I had the opportunity to partner with some good technicians, and now currently, concurrent with my office, I do have actually a CAD/CAM laboratory that's solely doing CAD/CAM techniques, and we have a variety of mills and ovens and things like that, and I just want to share a little bit with that for you in terms of where it's taken me and sort of the insights may have had just by basically, dumping into the water of CAD/CAM dentistry, and how it's impacted the way I practice and also my expected outcomes. So like I said, we are a fully digital lab. We do use the operating microscope both for our procedures, and also my technician will use it as well to do some of the work. This is our setup, just very sloppily put together collage. But I put this here only because I'm going to discuss some, and hopefully there may be others like me out there who are listening, who may be influenced, who may be a little bit hesitant, and this may be just a very small way to not necessarily discuss digital dentistry as an entity, but just show you some ways in which you may be able to enhance your practice if you are so inclined. But really what I want to talk about is going to be about dental ceramics and the ceramic options we have. Now, there are a variety of dental ceramics historically that were out there and that are available today. And I would say about 10 years ago, the field was, I'm going to say, a bit broader, only because there was such a revolution, if you will, of new products. So one company would come out and then another one. And so it became very much a, you would see these, I never forget, you would see these lab prescriptions, right? And you would see like 50 different products labeled, and you're like, how the heck do I pick which one? Well, luckily through evolution and things like that, really there's pretty much two main ceramic materials that are, I would say, by industry statistics, used the most. And so when we're looking at our options, Uh, I'll pick one for each category, but basically, if you want to know how to define a ceramic and how you can best use or utilize a ceramic material, it's best to know what category it sits in. And now there's a number of different ways that we can categorize dental ceramics. You could do things like fusing points, and you could do things by fracture toughness, but from a very clinically relevant point of view, I think that if you understand dental ceramics in either one of these two categories, I think you're more than 90% there. And the first category is glass ceramics, and the second one would be what we call oxide ceramics. Now, glass ceramics are a stranger to no one, because all of us, no matter if we've graduated 40 years ago or if we graduated last year, likely you're doing some sort of porcelain fused to metal restoration. So in that way, you probably have the most, I would say, historically utilized and most well-known type of ceramic material, and that's namely feldspathic. Now, feldspathic is usually the porcelain and the PFM. It's the porcelain and the porcelain fused to zirconia. Early generations of porcelain veneers were typically feldspathic. Now, I'm not showing you too much about that because most people have familiarity, but as a standalone used material, feldspathic, I believe, has pretty much aged out in many ways. And I would say by far, the most commonly used, and again, using industry statistics, of the glass ceramics would probably be some form of lithium disilicate or lithium silicate. Now, there are others who are still out there, such as people who enjoy to use things like lucite reinforced, and that would be something like Empress from Ivoclar Vivadent. It is a fantastic material, absolutely aesthetic. Dr. Hornbrook showed many cases using Empress, but I would say that in terms of its usage, it has declined, certainly from our clients, certainly for what I've seen when I was a consultant with other laboratories in the past 10 years, and definitely the majority of glass ceramic out there today would be lithium disilicate. And many people use it, and the thing is, erroneously, we call it Emax, Emax, Emax. And just so that to make it clear, that's not entirely accurate, because there are actually two versions available of the material we call Emax. And so there's typically something we call Emax Press, which is typically made in a dental laboratory from a wax up. And then there's Emax CAD, which many of you know, made from the those blue blocks, and I'll show you that in just a moment. There's other versions of it as well. Sorry, let me just turn this down. Okay. Now, the beauty of lithium disilicate over other glass-based ceramics, such as feldspathic, was that you were able to do this via a lost wax technique. Now, for those of you who may remember it, and I'm certainly aging out myself with this, is that we used to do gold in our dental school undergraduate training, and you would do your wax up, and then you would do a burnout, and if you were lucky, you got to spin gold and throw flux and make the whole light show. And the beauty of gold was that it had very, very accurate margins, because essentially, if you did everything correctly, you would have a one-to-one representation of your impression to the restoration itself. The problem with things like feldspathic veneers is that you would rely sometimes on the resin cement and your adhesive protocol to ensure that you had a good retention and to fill in really any voids or gaps. The nice thing is that Emax Press is made very similarly to the way that gold was made, in that it's made from a wax up. There is a pouring of a model, an investment, a divestment, and then instead of spinning the gold, the material is heated, and I'll show you that. That's that little ingot that you see by the press, that little thing that looks like a cylinder. It actually gets heated and pressed into the form, and you have a very, very accurate model. Now, there's also the milled version, which is what we're doing in our laboratory, and it has a fairly good marginal integrity as well, or accuracy as well. The nice thing about lithium disilicate is that it's one of the first glass ceramic materials to have very, very good flexural strength. By comparison, feldspathic typically had a flexural strength of about 90 megapascals. Empress or lucite reinforced glass ceramics hovered about 180. So now we're looking at something that was more than double the strength of Empress or Lucite ceramics. So it's quite strong as a standalone crown, not necessarily as a bridge, and we'll talk about other materials. Now, when we made glass ceramics, just so you have some idea, maybe to entice some people, the first thing we do, whether we're doing it in press or CAD form, is that we want to make our design. Then the material gets milled or pressed in the manner that I spoke about earlier. If you're going to mill, one of the things that you want to do, is that you have to do, is that you're going to turn that blue tooth, literally, blue tooth, and you have to increase the crystal size into an oven. And that crystallization will then harden the material. It will take it about 3 times. It will rather increase its flexural strength about 3 times by this process, and will also give you a shade that is the one that you had selected. Then to increase any type of aesthetic outcome, we want to apply some staining or any glaze. And then finally, to increase retention, whether you're going to, especially rather, if you're going to do a adhesive protocol, like in a restoration such as a veneer, you want to place some hydrofluoric acid in the intaglio of the restoration. And of course, this is one of the best advantages of glass ceramics, is their ability to be selectively etched, to selectively remove any glass or silica from the restoration, so that you have a very, very strong bond strength to the tooth. And again, I would just like to put it out there for anyone who is listening. If you have any questions about any protocols of the materials that you're using, please feel free to post it, rather to write it in the comment section, or I will also post my email at the end. And if you care to discuss any cases, please, I absolutely will welcome that. The thing about milling, and I'm going to talk just a tiny bit about that, about milling glass, is that it always has to be done wet. So there's certain care that has to be done with the machine to ensure function. If it goes dry, you run the risk of damaging the glass within the ceramic. So always it has to be done wet. So whether you're going to mill a block of feldspathic, whether you're going to use something like Empress block, or if you're going to use any of the lithium disilicate blocks, you always want to mill them wet. And this is a very popular mill I guess, setup, because this is exactly how the in-office milling units are designed. So things like the CEREC or Planmeca, all the other ones that are available, all the ones that will mill something like lithium disilicate or other glasses, they will always do it wet. But there are other millings units available, and that's the one I would like to discuss in a little bit, because by far the wet mills, as we call them, are more popular for in-office use. But as this is an academy that teaches quite advanced implant techniques, I might want to stoke a little bit of fire about other milling units that may be cost effective and available. And just for disclosure, I have no relationship with any of these companies, just what I've noticed in terms of productivity. So just as a quick summary, because I didn't want to spend too much time on materials, because Dr. Hornbrook did an amazing job, but there are 3 things about glass ceramics, regardless of what they are, that I want you to keep in mind. And that's one, that they tend to be quite translucent, which is why they're used in a lot of AACD accreditation cases and just on our patient choices, because they tend to look quite beautiful, because sometimes they can pick up the undercolor of the patient's tooth and provide a very nice and aesthetic outcome. But please know that opaque options are available, and we're certainly going to discuss that later on. Because of the ability to selectively remove silica from the restoration, glass ceramics certainly, as of today, as of right now, tend to have a much higher bond strength than other classifications, meaning the oxide ceramics available today. By comparison, also, they tend to be weaker than the oxide ceramics. So just keep those 3 factors in mind when you're selecting them, and we can see where we may want to favor one type of material over another. So, for example, I tend to place my glass ceramics in the anterior region, where we can take advantage of minimal preparations, where we can take advantage of translucencies, where we can take advantage of the ability to bond more predictably than we can with other types of ceramic materials. Now, here's the thing, and here's the issue, if you will, with glass ceramics, and it really amounts to choices, because there are quite a few choices you have to make as the clinician or as the prescriber to the laboratory. So I would like to show you this case. This was a patient that came to our office, and first looking at this crown, actually the shade selection, I actually think was quite good. I don't think there was a problem with the shade, though we can see that there certainly is a problem in the mid-body to cervical of the restoration. And certainly this likely came from the selection of too translucent a material. That said, I would like everybody to just consider this point. Is translucency always good? I was going on before how translucency is a very nice attribute of glass ceramics, but is it always necessary? And we're going to talk about how we can play like that, because is this a case that we have to do as, say, a PFM or a more opaque restoration? And I would argue that no, absolutely we do not. And hopefully by the end of today's presentation, I'll show you how we can tackle something where, such as a case like this, where likely underneath that crown, there's a metal post or some discoloration from a endodontically treated tooth. So getting back to these ingots and blocks, you can see sometimes we can make wrong selections, and sometimes unknowingly we can make wrong selections. Now, when you go to select one of these, or you're going to talk to your laboratory and say, hey, you know, dear lab tech, give me a B1. Right? It's not always so easy, and here's why. Because your lab technician is going to take your prescription of B1 and say, okay, B1, but do I want it in high translucency, medium translucency, low translucency, medium opacity, high opacity, or they have these other versions that are available. I'm not going to go over too much. Just know that the most translucent ingot or block available is called an opal. I want to make that point. And the second thing is, if you are interested in doing a lot of wet milling, in other words, using the CAM version of lithium disilicate, just know that there is currently no high opacity block available that I'm aware of. So if you want to have a high opacity restoration, it would have to be done in the pressable form, and it cannot currently be milled. Keep trying to bother Ivoclar to change it, but there may be coming out, some manufacturer may have a comparable HO or high opaque ingot, but as a block. But as of right now, there is none that I'm aware of. Why am I showing you all these blocks and ingots? Well, one, it's a lot of options, which is good. I mean, it's like cable television, right? You know, when I was a kid, we had 10 channels and one remote control. And that was my father telling me, hey, Artie, get up and change the channel. But now with streaming and cable and all these television stations, we have choices. And choices are good, but if I want a B1 crown, you know, it's not so easy to tell the laboratory, hey, give me a B1 crown, because for any Emax or lithium disilicate restoration, your lab technician is looking at 56 possible ingot or block choices. And I guess it would be 55 for blocks, 56 for ingots. But there are a lot of colors and choices that we have available. So please keep that in mind, and we're going to definitely discuss this when it comes to laboratory communication, which, as I said earlier, is one of the questions or concerns that a lot of the attendees in our class have about getting accurate results. So here's a restoration that, for me, looks quite good. I think they did a pretty clean preparation for the most part, maybe a little bit thicker than would need be for a monolithic restoration. This looks quite monolithic from what I can tell. But what's the problem here? Is the problem the failure of the material, or is the problem the failure of the operator? How would we prevent this, in other words, from happening? Well, there's a very simple way to do that, and that is to prepare this tooth more, right? Because if you look at the occlusal surface, you say, whoa, that's really thin. That's underprepared. Yes, maybe, but my answer to that would probably be, well, it depends. It depends on what material you're trying to use and where you're trying to use it. Now, this looks to me, and I believe it was it's a first upper molar. Can we use something like a glass ceramic there? And absolutely you can. And of course, it depends on a number of factors. But please be aware that lithium disilicate is not quite a strong material. So is there a stronger material we can use as an option, or is the only option we have to prep? And the reason I'm mentioning that is if all of us have done porcelain fused to metal restorations, and I always say this in my class, but have any of you done a coping try-in? And when you look at a coping, it's quite thin. It can be to no more really sometimes than a 0.5 millimeter. But what is the occlusal reduction necessary for a standard PFM restoration? Okay, and we know it's 2 millimeters. But why is the coping so, if the coping is so thin, why do we have to prepare so much? And of course the answer is because you're going to overlay that with an extremely weak material. So the reason you prepared so much was not biology, but really to make a very, very inherently weak material function, not be stronger, but function more strongly in the mouth. And what you could have done in a case like this is prep more. But is this where we have to go? Especially for those of us who advocate the use of minimally invasive dentistry. And of course, if we don't want to prepare more and make a weak material act more strongly, what we can choose is a slightly stronger material. And so that brings us to the next category of ceramic materials, and that's namely the oxides. And this is what I think, in terms of really market share, the majority of people are really using out there today. And that's, of course, about zirconia restorations. And we know that zirconia are available as layered, meaning you can use feldspathic porcelain on top of it, or as it's more commonly used in its monolithic form, and that's where the whole restoration is made of one material. Zirconia and all oxide ceramics do not contain glass. So what does that mean? Well, that means that we have to have certain precautions taken to try to improve any type of bonding that we can. And there are some techniques we have. Now, as of right now, and I always have to say, what is that old saying? If you quote me, date me. As of today, the bond strength, predictably, of glass ceramics to enamel is still quite significantly greater than that of enamel to zirconia. But there are certain things we can do to improve that. I'll discuss it a little bit, and especially when it comes to implants and where we have an issue with that. Now, the nice thing about zirconia is that it can be wet or dry milled. And it is one of the materials that is truly indicated for not only posterior, but I would also say for also long span bridges as well, meaning full arches. And we know a lot of people, especially who are trained at the IDIA, who are very, very advanced operators who are doing full mouth rehabilitations using zirconia as a template or as a platform. Now, the flexural strength of zirconia is interesting because when I first came involved doing a little bit of zirconia research, it had a flexural strength of about 900 megapascals. Okay, and you can say, well, with better formulations over the past 10 years or so, that it can get stronger. But why on earth would a material get weaker? I'm going to show you why, and just some things to be aware of. Now, this is just a photograph of our mill. This is a dry mill of a zirconia puck, and this is what typically it looks like. It's basically looks like a big hockey puck. You place it into the dry mill, and it's done. It does create a lot of dust, so you do have to be careful in terms of filtration and things like that. But this is a very efficient way for those who are doing a lot of zirconia. And the way we do monolithic zirconia, very simply the same way we design it. It gets milled, and as you can see in the photograph on the right, there's a tooth form. You just pop it off the disc. It's quite weak before it gets sintered. So in this state, it's very, very kind of chalky looking. You remove it, remove the sprues. Then what you have to do is you have to sinter it. Now, the reason I'm saying that is because there are also blocks of zirconia there as variable as well. There's things like Ivoclar has a Zircad, where you can actually wet mill. Actually, you can wet or dry mill, but typically it's wet milling zirconia from a block. I'll talk about that in just one moment, or I'll just talk about the advantage of the puck in terms of volume. But it does have to be sintered, so it is another step. The blocks are pre-sintered. The ones that are made typically from the discs are stronger the flexural strength of the block is about 850 megapascals, where the ones from a puck can come up to about up to 1200 megapascals. Although there are some formulations that are kind of combining it, and I'll kind of get into it in a bit, where they're combining different types of zirconia. So they actually will have a stronger form and a weaker form. And then to improve the aesthetic appearance, you can stain or glaze the material. And then to improve bond strengths, one of the things you can do is you can air braid using aluminum oxide. And I'll show you one we can use that you hopefully is a situation you will not have to run into, but even if you're not interested in doing any type of milling in office, excuse me, that hopefully will be a way to improve an outcome should you have this problem, and I'll show you that in one moment. Now here is what monolithic zirconia looks like. It's actually monolithic, and I should say monochromatic as well. On the left this is what it looks like as we remove it from the puck. These are identical crowns fabricated twice. The one on the left is as it comes out of the mill, and the one on the right is as it comes out of the sintering oven. And you'll notice, of course, very obviously, that during sintering, there is a volumetric shrinkage of the material, and that's where it provides its strength. The next step would be to stain and glaze it just to enhance the aesthetic appearance if desired. But just know that if your zirconia ever breaks for some reason, you have a chip in your monolithic zirconia, or quite frankly, just be aware that if you have, let's say, this is where it happens more, because these guys typically will not break. But if you try to put in a crown, and this happened to no one else, I know it only happens to me, but you try in a crown, adjust it, it's too tight, adjust the contact, try in the crown, adjust the contact, and then it's like, oh, it's pretty good. And then you go to polish it so it's smooth, and then you put the crown back in, and the floss just, you know, smacks the gum with no contact. Just so that you know, you cannot really add zirconia to zirconia. What laboratories will typically do in that case is that they will, if you send it back and you say, hey, listen, I got an open contact, or just blame the lab. It's just easier to say that you did it, it's your fault. And say, hey, the contact was open. Typically, if they do not remake the crown, what will most likely happen is that there will be an addition made, usually with a glass ceramic, and typically, so far as I know, with feldspathic porcelain to it, because they can add to it and get pretty decent adhesion of it. But just please be aware that if you have an open contact, you know, you don't necessarily want to tell the lab, hey, make it over, but just be aware that that proximal contact may be actually in a glass ceramic, even though you have an otherwise monolithic zirconia restoration. I'm just going to throw this out here, and if anyone wants to take a photograph or go over this, I'm not going to go into it. It's a Saturday morning here in New York. But I do want to tell you that you're going to see a lot of advertising, and it happened earlier this year, where a lot of companies were promoting, we have 3YTZP, we have 5, we have 4, and like, you know, what the heck is all of this? Well, when zirconia first came out, it was always advertised as something they called 3YTZP zirconia, and it was touted because it was really strong. And what that essentially means is that zirconia is a very unstable element in its tetragonal form. So there's basically 3 shapes of zirconia. I promise I will not torture you all with this, but I just want you to know that to keep zirconia stable, they have to add a metal to it. Typically, it's something called yttria. They also use the metal called ceria, which I thought was going to be more popular, but yttria proved more popular. And they would use it to help keep the zirconia stable. Now, the thing is, the less yttria, in other words, so what that stands for is that's by mole percentage. So the less yttria, the stronger the zirconia. The more yttria, the more translucent. So as we progress from left to right on the screen, that's actually a less translucent to a more translucent, though not very translucent yet, but it is getting better and better. So there's a 3YTZP to a 4YTZP, and then finally to the 5 form. And the 5 form is sometimes you'll want at the incisal edge. So some of these pucks will actually have a combination. I know Ivoclar's Zircad Prime, I believe, has a 3Y a TZP and a 5Y TZP in the puck itself. And again, that just stands for 3 yttria tetragonal, yttria stabilized tetragonal zirconia polycrystal, which for the manufacturing or marketing gurus out there was not a very easy thing to say. But just know that if you see a Y, 5Y they'll call it, or a 3Y, that the 3Y tends to be stronger. So if you're doing something like a second molar, don't say, hey, you know, don't give me a super translucent one. Maybe I want to use the strength. Because conversely, we can see that the strength for the 3Y is certainly stronger than that for the 5Y. And again, usually the pucks will have a higher strength, typically around 1,000 to 1,200 megapascals, and the pre-sinter blocks sit in somewhere about 850. Now, one of the things you might want to look out for is also cubic zirconia. I said zirconia exists in 3 forms. One of them is cubic. And that tends to be quite, of course, very translucent, in fact, almost transparent. So now a lot of companies are adding stabilized cubic zirconia particles, and it's giving you a much higher aesthetic outcome. Now, the question is, you know, how much is too much and where do we need to put things, right? Because as we get more translucent, we're always going to lose strength. Now, right now, the most translucent zirconia available has I believe it has a flexural strength of about 600 to 650 megapascals. So that is still 100 megapascals stronger than the strongest Emax press. And if I didn't make it more clear, Emax press is actually a little bit stronger than Emax CAD. So also please bear that in mind. But you know, there are advantages. Where would you use this translucent? Now, if you're going to use a very translucent zirconia on a second molar, I mean, is that necessary? Maybe. And then at what point do we want to use some of the advantages of glass ceramics, which I will go over going forward. So again, as a summary, the oxide ceramics tend to be more opaque, but they tend to be stronger. In fact, not they tend, they are still quite strong. So as this is the IDIA, I don't place a lot of implants. I have a fantastic surgeon, Dr. Avi Stern, who does them for us. But I just want to show this not as a case presentation, but more as a materials presentation, because I think that if you are interested, and I know there's some very highly motivated, highly tech savvy doctors listening and who are part of the association. This is a standard and there's nothing spectacular, you know, in terms of any techniques here. It's beautiful surgery by my surgeon, but I just want to point out that and again, Dr. Oliveira is going to discuss this next week. But in terms of ROIs on equipment, I do just want to point out that the best piece of equipment I think you can get in terms of ROI, if you're interested in doing implant dentistry, would of course be the cone beam. The CBCT machine, I think, will give you the highest ROI. How? Because I think it's going to give you the best peace of mind, and I think that's invaluable. But if I had to pick a number 2, I would say likely it's to consider getting a 3D printer. They're very affordable, and you can use them for printed surgical guides. You can use them for things like orthotics. You can use them for splints. You can use them to make aligners for orthodontics. So I think in terms of financial ROI, the 3D printer, I think, would be a no-brainer. And if you're doing a lot of implants, I think that this would certainly be a good way to make a very good decision, because you have a lot more control this way. So anyway, this is just a long span bridge, a lot of implants. This was done via a third party to do a surgical guide, which we printed and put in the sleeves. You can also use the dry mill to make a PMMA provisional. Now, the reason I brought this up is only because, and this is what it looks like coming out of the mill, because you can get a wet mill. And I, again, use a wet mill in my office for our glass ceramics. But the advantage of having a dry mill, number one, is tends to be cheaper. You'd be surprised, it actually is a little bit more equitable than a wet mill. Not that I'm not advocating a wet mill, because I think that's valuable as well. But for those who are doing cases like this, who are doing full mouth rehabilitations, who are doing large, long span bridges, you have a lot of control. You can have a very good ROI, and it's a very, I think, cost-effective piece of equipment to not necessarily invest in, but to consider looking at. You know, when I first started, everybody wanted to get those wet mills because it was cool to do it in the office. But as I started to progress, I saw that really there was a lot of advantage to having the dry mill. And I'll explain with this next slide, but you can make your PMMA provisionals, and you can use the puck, and you can make these very large things. Now I want to show you this picture because this is what the case looked like after it was done with the abutments on. But if you see that puck, you can get likely, I would say, I think the most I saw was, I think, 25 or 26 units of cases there. So if you're someone who's doing a lot of single unit zirconia, or you're doing these larger arch cases, a dry mill may be something you want to consider. You would also have to get, obviously, a sintering oven, but to be fair, with a glass mill, wet mill, you would have to also get a crystallizing oven. So it almost offsets, although the sintering ovens are more costly. But if you're doing a lot of single unit zirconia, or if you're doing these large cases, you may want to consider a dry mill because the cost for a block can be a little bit more than the cost for a puck. Remember, per each puck, I think, which costs about, I think, $2 something, you can get something like 25 units out of it. So if you are doing a lot of it, a dry mill may be what you're using. And I'll tell you, in our office, this certainly is a workhorse. This is a Roland 51D. And we're using it constantly. And that's just because it's just so many people are prescribing zirconia. And that's a very easy way to do it. And also the maintenance on this is quite low compared to trying to wet sinter zirconia, because the burrs will wear much, much more easily and much more quickly. Here, the burrs tend to be a lot more, you can do a lot more cases per burr, so your overhead cost on it can be quite low. Also, there's less maintenance with the oil and with the water. Anyway, the other thing, and I just threw this out there because I'm a big fan of this thing, is to use a operating microscope. You know, once you start getting, it's like a drug, you can't stop. But I have been using a microscope for the past 6 years prior to my involvement in a laboratory. But, you know, the beauty of it is you can really see everything you need to see, and it really makes dentistry a lot more pleasant to use the operating microscope. And this is the before and after case. And like I said, the only reason I'm showing you this is because using a good lab, using good digital technology, you know, using appropriate techniques, really to do this case, the most labor intense part of this whole case was really just doing that direct composite on tooth number 26. It can be that easy. So again, I just put this out here to consider some options for those of you who are doing a lot of zirconia or larger cases. Sorry. So earlier I said, you know, there are some differences with zirconia and lithium disilicate in terms of one being glass free and one having a lot of glass in it. So etched glass, again, to reiterate that point, really helps with our bond strength. Etching glass increases surface energy, increases surface area available for bonding. So what the heck do we do with zirconia? Because it's quite strong. It's not etchable because there's nothing to etch, theoretically. Now, there is something that can happen. And again, if you're not interested in purchasing any mills or anything like that, I would say that here's a principle of zirconia you should know, because this may happen to you, especially if you have a laboratory that is not following its own protocol. Patient gives you a call and they say, "Doc, I think my implant broke." And there's nothing better to hear on a Monday morning than, "Doc, I think my implant broke." And you go in and, you know, you take a look and you're like, "Oh my gosh, what is that?" And you unscrew it and you see, obviously, all that really happened was that the zirconia crown separated from the tie base. This is like, almost think of it like a stock abutment that you can use. And so, you know, is this case ruined? And obviously not. So, but what's the best way? What's the best way, utilizing some of the principles Dr. Hornbook spoke about, to fix a situation like this so it doesn't happen again? Because is this a case you immediately have to send back to your laboratory and say, "Hey, you messed it up, fix it"? The answer is absolutely not. This is something that can be done very easily in your office. All right, so what is the protocol? Well, this is just a photograph of a, you know, a representation of a tie base. And so if you're going to put back your screw-retained crown, these are the steps I would suggest you follow. First thing I would do is I would put some Teflon tape, some PTFE in the chimney. Actually, first remove the screw, then put some PTFE in the chimney, and then also protect the area of the abutment under that lip. You can see how maybe this will help. You see there's that lip there. That will be your margin, if you will. This is your shoulder margin. Cover it. And also plug the chimney or the access hole with Teflon tape. Then what I would suggest, and they're quite affordable, there's various versions of this, I would suggest that you consider using 50 micron or 53 micron aluminum oxide in a air abrasion unit. I'm not going to go into it, but if anyone is interested, there's also something called tribochemical etching, and that would be something like a Rokitech, where you're trying to impregnate silica-coated aluminum oxide into the intaglio. But from studies I've seen that bond strengths of just using aluminum oxide, but it has to be the larger one. It has to be at least 50 micron with some pressure. Now, it depends on the manufacturer. You can do 20 to 30 PSI, anywhere 2 to 3 bar for those listening overseas. And then what you want to do is, after you remove it, try to rinse out as much aluminum oxide as you can. I would suggest using some kind of alkaline-based zirconia cleaner, something like IvoClean or BisClean from Bisco. And they're quite good, and they will help remove any phosphates that may be lingering, although likely, if you're not using this, usually the aluminum oxide will do it, but just to really maximize. Then what you want to do is you want to place a zirconia or metal primer in both the crown and around your tie base. And these are usually some type of methacrylate-based primer. They do have phosphate methacrylates that will help bind to zirconia. They also have, just so you know, they do have methacrylates that will help prime for bonding to precious and non-precious metals. So I would paint this on the intaglio of the zirconia crown, as well as all around the tie base. And that will help improve your bond strength. And then finally, I would absolutely suggest that you use either a dual or self-cure resin cement. A lot of people like to use an MDP containing cement, and MDP is one of the primers that is shown by far to have an affinity for zirconia. Can work. Typically, if you're using the primer, it does have some variant of 10 MDP, and that will help improve your bond strength. So take this protocol. I think you can do this chairside. This is not something you have to send to the laboratory. And just to show you that you can actually do this in your office if you consider milling. Both, you can do it with a stock tie base, and you can mill your zirconia. Or if you're up for it, even a lot of the wet mills today allow you to make a custom abutment. And they have to be milled wet, though. So please just keep that in mind. Okay. So with that said, I'm going to talk now about some lab communication issues, and we're going to delve a little bit away from implants, but just now into how we can improve our communication with our laboratory to help maximize our outcomes. So the issue a lot of times we see is we'll have a patient come in and they will, have some teeth, say, hey, doc, can we do something about this? And they say, okay, sure. So we prep our teeth, right? Then we would take our impression, send that to the lab. So this is what we would see. But this is what your lab would see. They'd see something purple or green or cream colored. And the question is obviously, how do we get together to create a result that would be something that we're looking for? And so what I want to discuss now is how we can best communicate shade to maximize the outcomes for our patients and really for ourselves. For those of you who are not, I do advocate the use of digital macro photography. This is my current setup. But really, can you do photography and photographs to your laboratory using a mobile phone? And the answer is absolutely. And I think this is the photograph you need. Now, this is a photograph that I would love to see more in a lab. I see a lot of single shade stumps, but basically, if you're going to send a case to the laboratory, I know a lot of them, certainly the ones I worked with, would appreciate a photograph like this. Now, why? Basically, what you want to do is you want to put 3 shade tabs in the same plane as the prepared teeth. And the reason I say that is because you can even have them touching the teeth, edge to edge. And the reason I tell people to do that is because sometimes they'll place the tabs too far forward away from the patient's mouth. And what will happen is that the shade will look lighter because it's closer to the light source, or you have the people who really put the shade back, and then of course it will start to look darker. You can put the likely shade in the center, and this also will allow your laboratory to see the prep shade of the teeth, although there are specific prep shade guides available. What I'll then do is I'll take the same photograph. So that I took that photograph with the shade tabs, I will myself convert it to grayscale, and there are many free software available either for download or online that you can use. And what you do is you'll make a copy and you'll convert that one into a grayscale photograph and send that. Now, why do we want to send the grayscale? Because it will help us evaluate the inherent brightness of the material. Now, a color lecture is its own 3-4 hour lecture, and for today I don't want to go too far into that, but please just know that black and white photography is a really fantastic adjunct to shade selection. And a lot of it has to do with the fact that we may have more rods than cones in our eyes, so we're better at discerning variance in black and white. A third option is this one. Now, I showed you with black and white and the regular photograph that you just basically make a copy. But what you're looking at here is not a duplicate. These are actually two separate photographs. The one on the left is the standard photograph. The one on the right is something that we call a polarized photograph, which many people know of. And the advantage of using a polarized filter on your camera lens is that it removes, as you can see here, there's no light coming back. In other words, it removes all specular highlights. And this is a very nice way to help with choosing a shade. And one of the most popular ones on the market is something called Polarize. It's made for a ring flash or a twin flash. And really there's no difference in the image because I shoot with both. And I've actually just to say I've gone to using my polarized filter on my ring flash because it's just one piece versus the 3 pieces you have to use for the ring flash. So if I had to make a choice between, and you have both types of flashes, I would say just put it on the ring flash. Makes it very easy. There is no difference because you remove the effect of light. So again, for our laboratory, I'll take my colored photograph. I'll also take a second one with the polarized filter so that when I'm sending my photographs to the laboratory, I'm going to send them a color one. Then I'm going to duplicate that and create a grayscale one. And then often I will provide a polarized photograph as well. And what this is, again, if you look at it, you're giving your technician 9 different options to help to make a decision in terms of shade. And we haven't even begun to talk about this color dentition yet. The one thing I'm going to ask all of you, and if you want to have good relations with your lab, is you want to take a photograph and you say, okay, I'm going to do what Dr. Volker said. I'm going to take this, these pictures. Don't do this. I've seen this more times than you would think. And, you know, take the dentist is saying, okay, I'm going to take my shade photo, and they send the shade photo and they send everything to the laboratory. And then you get it back and you look and you say, that's great. What shade is it? And it always gets cropped or cut off. So it's very important to put that. It's a small point, but it's one of those where I was shocked by how many people actually inadvertently cut it off when they emailed it. Another option for those who may not want to invest in getting a polarized filter or who are using their mobile phone is to a very simple hack is on those photo processing software is to just increase the chroma, and you'll just create a very hyper-saturated photograph, which will also help the laboratory. And these are 2 of the same photographs. You make a copy and just increase the chroma, and that may also help the laboratory discern some differences. Is it optimal? No, but it's free. And dentists, we love frugality. It's in our name. Okay, now I want to talk about determinants of final shade. In other words, what are the factors that will help impact the optical outcome of our restorations, right? And let's go to glass, because glass, again, with all those choices, they really give us a lot that we have to consider, right? Because again, glass provides us translucency. And we're gonna see, is that good or bad? I showed you a case where translucency was bad. Bondability, which is really great if we wanna do something like a veneer or a restoration that is relying on adhesion instead of retention. And also it's weak. So let's talk about glass ceramics and what will determine the final shade of our glass ceramics? Well, number one, obviously, is going to be the shade of our preparation. Secondly, will be the shade of cement, and the more translucent the restoration, the more of an impact that cement will have on the final outcome. The thickness of material, I'll show you that in just a moment. And then also the inherent property of the material. In other words, what will a high translucency look like versus a high opacity? And we can use that to our advantage. Now, life can become a lot easier this way, because years ago, if we wanted a B1 in a PFM, we just say, hey, dear lab, give me a B1. And that was pretty much it. That's all we needed to have, because the materials themselves were so opaque, because we had an opaque metal core to cover, even with a material like Procera, which is an oxide ceramic overlaid with a glass ceramic. That very opaque oxide coping from the Procera would mask any dark color. So it didn't matter. Now we have to be more careful, especially to improve aesthetic outcomes. So really, this is going to come down to choices. Right, so let's talk about some ingot and block selections and what we can do and where we should do it, more importantly. Right. Again, look at our 56 options that we have per case and say what would be the best one to use and where. So what I'm going to go over now in our last portion of this presentation is I'm just going to go over cases. And just show you what we do, where to do it, and how to avoid some mistakes. So this patient came in, felt the teeth looked a little bit small, had some failing composite restorations, a little bit of caries. And this was our preparation, and it's done with the microscope. Now I apologize, there's a lot of brown reflectance, but the teeth were caries free. And again, the preparation was done under the microscope. So we were able to keep the preparation quite small. So we sent the photographs to the laboratory. In this case, we sent the 3 of the identical pictures, 1 color, 1 in grayscale, and 1 hypersaturated, just to help the technician and us make the decision. But here's the game, and this is where I want everybody to hopefully get some tips from, and that's the shade of our preparation, right? Because it has an impact, is, let's say, about A3 or so. But we want the final shade to be A2. Now, the shade of the cement that I like to use, and you'll get the trend very quickly, is I like to use a value 0, also known as a translucent, also known as a clear cement. The material thickness, I mean, we say 0.3, but there wasn't much to touch there. Who knows what the difference between 0.3 and 0.5 is really. But the microscope certainly helps guide your preparation, makes it much, much easier. And we took about 1.5 millimeters off the incisal edge. And speaking with the technician, because the teeth were so close to the final desired outcome, we can use the underlying tooth structure to help mask, I'm sorry, not to help mask, to help enhance the aesthetic outcome. And so this is what it looked like about a week later after delivery, and you can see, or maybe less, you can see we had a very nice aesthetic outcome using a very high translucent material to help take what's underneath and provide, like I said, a very, very minimally prepared and in my opinion, quite nice job by the laboratory. Okay, so let's take this second case. And so that was something using a high translucent where we want to mimic what's underneath. Let's take a look here. This is a patient came in, right, failing crowns, failing restorations. We took our shade, we took our value, we took our color, but I want to show you the preparation. Now here's the preparation, and this is something we called a defect-oriented preparation from Bitter, who was the author, which is not a great name for a dentist, but was the author nonetheless. And I want you to take a look here. Look at the adjacent teeth, and you would say, hey, that's pretty close. Why don't we take some of the color from the existing tooth and we can use that to enhance our aesthetic outcome, right? Hold on, because I want to just show you one difference between the preparation for this case and the preparation for the last case. Now take a look here at this interproximal area, or in other words, take a look at this negative space that we see between the centrals. And a lot of times, especially early on, a lot of doctors would prescribe or say, hey, I really want a translucent material because, you know, my stump, my underneath color looks quite good. So I want it enhanced, but you don't. Because what you're looking at here is you're looking at a very dark negative space. So in that case, in a case like this, I do not advocate necessarily the use of a high translucent material. Why? Because what will happen is in the negative areas, in that interproximal space, it may look very, very gray. So in these kind of cases, I'd advocate something like a medium translucency or a low translucency. So in this case, even though the stump shade was very close to our desired shade, I still would opt for a low translucent. And I'll show you ways that the laboratory can get around that. The shade of my cement is clear. I always prefer a clear or translucent cement. I want to try to control this variable. You know, I always make a joke in the lectures and I say, you know, there's no atheists when you're trying in different veneers for different stump shades, because you're putting one to the other. All right, let me go to white. Let me switch to yellow. Right, it's like, please, 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 right? There's no atheist then. If I can control one of these variables by taking out and keeping a constant, I can use the others to help modify that. So in this case, we had our preparation, again, minimum of 1.5 on the incisal. And in the material properties here, because we wanted to make sure that we adequately blocked out the negative space interproximally, we opted for a low translucent. All right. And so this was what it looked like after postoperative, came out satisfactorily. And this is the most important thing here, is that I believe you do not see any negative space on the interproximal. Okay, then you come to a case, you say, well, what about a single central? Because as we all know, that's one of the hardest things in dentistry to do. And this was a patient who came in following a 3,000-pound pole that whacked him in the back at work. How this guy survived is beyond me. And so he came into the office and we said, all right, for now, because he was still in the brace, we're going to just address the fractured tooth. And it was quite fractured. This was some temporary somebody put on. He came in and we're going to do a single tooth veneer. Now, again, using the microscope and using things like Galip Gurel taught and David Hornbrook taught, is that we want to keep our preparations as minimal as possible to be as precise as possible. And as you can see here, using the operating microscope, I think we were able to achieve quite a good result with a very, very thin margin. I apologize, the film's a little bit grainy. I had to stretch it out, but again, that's the beauty of using illumination and magnification in your armamentariums. You can see we have very clean, you can see it, it's actually in enamel, clean, slight chamfer preparation. All right, and then to the laboratory, because it's a single central, we send the photos. So again, the first three are the same. They're just variants of each other: color, grayscale, and saturated. And then I took also a polarized, which I should have probably done a better job, because you can see it's a little bit more forward of where I should have put it. But here's the preparation. And you say, okay, this was minimally prepared. And again, I don't want people to fall into this trap. Again, look at the negative space. Because there is a fairly large negative space in this area, even though the tooth is barely almost scratched in some areas, you still have to be very, very careful. All right, don't get taken in that a high translucent will absolutely work here. Now, there's some fantastic technicians, without question, who will do this in a high translucent material. But just take caution, because it may not always work out to your favor, in that you may have some unwanted and unexpected graying of the material. So in this case, I spoke with the laboratory. I didn't want to make it look too opaque, so he said, we'll be good with a medium translucent. And here's the case the day of cementation. So I expect the tissue, whose patient was very compliant, to look better, but I just threw this in here for the presentation. He had to have a bunch of neck surgery, so I hope to get one. But you can see, by providing the laboratory with information, I think they did a very nice job of mimicking the color, for the most part, of this single central. So this was a far more minimally invasive treatment than to have maybe, say, done 2 crowns, which is something we see here. And that's in this last section of our presentation on treating discolored dentition. And does it always have to be a compromise? And here's what I mean. So when I was in school, and you had those treatment planning sessions, and the instructor would say, okay, Patient is a 25-year-old female. When she was 8 years old or 9 years old, she banged her front teeth on the, she banged the tooth on a tabletop. Tooth number 8 is now discolored. Tooth number 9 is absolutely fine. What is your treatment plan? Well, we know you have a couple of options. One, you can try to opaque it and do a direct composite, and often I will do that. You can say, well, patient is going to need a crown, meaning the adjacent. So tooth number 8, crown. Tooth number 9, veneer. Or you can try to match number 8 to number 9. And the most common treatment plan advocated was this. Simply do a PFM crown, tooth number 8, and do a porcelain laminate veneer, tooth number 9. Because the hardest thing to do, as we talked about, is to adequately match the single central. Say, okay, well, you don't want to do a crown on number 9 because that would be way too aggressive. So just do a veneer and you will be fine. Well, and again, another one of these cases where you have to be cautious, because in this case that you see here on the right, this was a patient where that exact same thing happened. She's presented with a crown on tooth number 8 and a porcelain veneer on tooth number 9. And they were done at the same time as a means to match the teeth and make them perfectly symmetrical. But again, because we're dealing with different substrates, tooth number 8 is dealing with a metal substructure, and tooth number 9 was likely a virgin tooth. I mean, now for us, it needed a root canal and a crown, but at the time, one crown on an affected tooth and a veneer on number 9, and you think, okay, it's great because they're both going to be A1. Well, here's A1, and we see that it doesn't work, and that's, of course, because of the optical properties of the materials themselves, right? So using dissimilar materials can result in both a chroma or value. They will result in a chroma and value discrepancy, meaning if you have a chroma discrepancy, likely you'll have a value discrepancy, though that's not always the case. So the question I pose to everyone is, to create uniformity, do we have to require both teeth to have equal preparations? Meaning, if I have a virgin tooth that on that number 9, do I now have to absolutely make that a crown? Because then we can do 2 PFMs, and then case solved. Now, what do we do if one preparation is more discolored than the other? And, you know, do we have a viable solution? Well, what are our options to block out a dark color? Well, one's very simple. We just talked about it. Why don't we use an opaque material? 2 PFMs, super opaque. Zirconia can be opaque, especially in its 3Y configuration. So we can do a crown on number 8, and we're fine. Crown on number 9 on a virgin tooth, well, okay, if we have to, and we will get uniformity. We can prep more. Definitely you can prep more aggressively, and there have certainly been studies to show that, and I'll believe I'm going to show you a quick guide about that. So you can prep more aggressively, but you know, is that something that we want to do ethically? I prefer not to. I prefer to, again, advocate minimally invasive dentistry whenever I can. And here's what I mean. This is just a ingot and block guide from Ivoclar, just showing you at 3 different thicknesses, 0.5 millimeter, 1.0, and 1.5. You can see that a couple of things. You see that the greater the thickness, the more likely you are to mask the discoloration. But also, if you take note, you can see that in some variants, specifically the A1, the thicker the material gets, the more gray it can kind of look. So that's something to consider, and that's what I was talking about, that graying of the negative space. It creates an optical disharmony, not a very, very good look. So what other options do we have? Well, we already talked about going to an opaque material, which is not necessarily bad, and I'm going to tell you, I think more people will go to zirconia, and you're going to see more people doing zirconia veneers. I'm not going to get into that now, but they haven't been around for a long time. The first time zirconia veneers, by the way, have been since 2008, when Adrian Jerome passed, but when he had done it at an ASDA meeting in Florida, in Hollywood, Florida. So we said, try to use opaque material. Then we said, well, prep more. We can try also an opaque cement. That may work. Or we can try to go with a more opaque ingot or block. So here's how we dealt with this case. This is how the patient presented. You can see the value discrepancy is there, but to be honest, the reason why this probably worked for the patient so well is because the value discrepancy was actually not as bad as the chroma discrepancy. And that's why sometimes, I'm not going to get into it now, but with composites, sometimes if you're close on the value, and that's why this black and white photograph is so super important, you can actually end up with pretty good outcomes, even if you didn't exactly nail the saturation of the color, the chroma. So here were our preparations, and you can see when number 8 was removed, it had quite a deep shoulder. Number 9 was prepared after the root canal. And this is what we ended up with. And you can see we have quite a dark looking metal post in tooth number 8. So we sent our pictures ad nauseum. I put that so that you all, hopefully it's something that will become a habit. So the patient wanted a B1 as her final shade. And we can see the shade of the preparation, once we removed the enamel, was about, A3 to, what do we call that metal post? Was he 50? Who knows? It was quite dark. The shade of the cement, again, I'm going to use a clear cement. Material thickness, now definitely I had bigger shoulders here. I don't think it was as necessary to prep number 9 as aggressively as I did. Number 8, really I had no choice because it was just where the preparation was. But in this some way, it did help me because it created more potential for opacity. And when I spoke with the laboratory, they suggested using an MO because he felt that there was enough thickness to adequately mask. So here's what the case looked like immediate post-op. And you can see, ended up with pretty nice. We're just waiting for gingival healing, but I show it just to show you that we were able to get a fairly uniform appearance of the teeth. Here's the value evaluation. You can see they line up quite well, I think. And this laboratory, again, did, I think, a very, very beautiful job on it. But I want to show you this photograph because we worry about translucency. And this is the point I want to make. The most translucent part about the tooth is always at the incisal third to the incisal fourth. So what really has to be masked is just really that mid-body. And then what the technician can do is they can add some effects, and this was done with an oral design laboratory. And beautiful work, beautiful aesthetic work, made a very, very nice aesthetic outcome for this. Now, there are other ways to opaque. I know Dr. Lane Ochi, who many of you know, in Beverly Hills, he advocates the use of basically a taco shell to cover the, almost as a coping over the discolored area and then the crown. And that absolutely can work. And he's a master of his craft, and that works. I have found that this works equally well without the extra step for myself. And now I'm going to come to my final case. And again, I want to thank all of you who've stayed with me for this. I know it can be a little bit tough on a Saturday. Hopefully it was not too much torture. And I want to show you a case that is not a pretty case in many ways, but sometimes we learn the most from the cases like these. And it's funny, usually people want to end the case on a high note and say, look how great that guy was. Here it's like, meh. But I think it's very important because there's a lot of things to be learned from this. So this patient came in, and I was her 5th consult or something like that. And she had concerns, and people wanted to do all sorts of things, and they want to crown. So she just came for an opinion. And I said, okay, let's take a look. And she had some issues. And as we can see, she looks like she has a bit of overbite. There was a lot of wear from using her crown on number 8, where it was a low fusing, likely a low fusing porcelain, which is very, very abrasive to the adjacent teeth. Just so that you know, the least abrasive material to adjacent teeth currently is glazed zirconia. So if it brings some controversy, I don't want to get too much into it, but just know that glazed zirconia is the kindest to the antagonistic tooth. But just know also that sometimes over time the glaze will wear. So some people are advocating, if you have anything to polish your zirconia surfaces, and there's some very, very nice kits from Comet, kits from Brasseler to polish your zirconia restorations, because the glaze will wear over time and can become a little bit abrasive. But still nothing like what we see with these worn older PFM restorations. So getting back, this patient has come in, has some concerns about the front teeth, has some large caries, large failing restorations and things like that. So we said we would address the 4 front teeth. So far with the cases, I've not shown any treatment plans because they're fairly straightforward. The reason I'm going to show you this treatment plan is because it's fluid, basically. And that's because of this. The first thing we always do is we have to create a very good, healthy periodontal base. Patient had some perio issues, not very compliant. You'll see at the end, she was not compliant really at all. So we want to try to get her healthy. And she was quite good during the course of treatment, slipped off. This case is about, I think, 6 years old now. We know we're going to replace tooth number 8. And we were going to do this case with Emax Press, full coverage crown. And now here's the thing, and the reason why I put up this treatment plan slide is because we decided we're going to treat teeth number 7, 9, and 10. But what are we going to do? Veneers, crowns, 3/4? So that's the thing. And my answer to that is whenever we're going to use glass, and now this is the beauty for me of glass ceramics, is this: I don't know. I don't know. It doesn't matter. See, with a crown, we are relying on retention and resistance form. I mean, technically we can bond it, true, but there is a, let's say it this way, there is a retention and resistance form inherent in our prep design. And that's what is done from using conventional luting. But with the advent of resin cements and adhesive protocols and the ability to etch glass, my answer to what we're going to do to the other teeth does not depend on the restoration. It depends on what I find. So the only thing that's guiding me is really going to be caries removal and restoration removal. So what am I going to do on the other teeth? Well, I may end up doing a thin veneer. I may end up doing a more wraparound veneer. I may end up doing a 3/4 crown, a 7/8 crown. I don't know. It depends, but I'm not limited because I don't have to make a specific form. And I'll show you what I think is the best photo of this case. So my answer to the other teeth is it depends. So here it is. It depends. When we took off tooth number 8, we had this really, really discolored tooth, again, with a deep margin, which is funny because if you're doing a PFM, you don't have to prep so aggressively. But this is what I found. It's interesting how many times I will take off a dark tooth, and it's almost like the dentist saying, well, I'll give the lab more room. They don't need any more room than a conventional crown because you're going to opaque it with that metal substructure. Anyway, so you can see tooth number 7, we had some caries out. Now, I'm going to show you an up close. I think I have it next. Let me see. Yeah, let me show you this right here. Take a look at tooth number 8, right? We have this very, very dark area. But I also want you now to take a look at tooth number 9, or the 2-1 if you're watching us from overseas. Look at the mesial margin. You see how it can be very, very thin? Because it was super clean, super clean. There was nothing there. It was basically a virgin tooth. But as you saw in the pre-op, she had a very, very large DILF restoration, a lot of caries. And so during the caries removal and to create a form, you can see that the margin is quite larger. Now, is that going to be an issue? No, because I'm still quite a bit into enamel. I'm going to use adhesive protocol. So if I had to do a crown on that tooth, and I said from the beginning, I have to do a crown on tooth number 9, that shoulder would be as big as the one on tooth number 8. And really, I was able to spare tooth structure. But I was actually able to spare tooth structure in a more important place in just a second. So again, the photographs, same standard as we do the others. And now she wanted an A1. So the shade of preparation ranged anywhere from a 2.5 to that really, really dark tooth on number 8. I'm going to use a high translucent cement, clear. The material thickness, and here it could vary. You know, it was 1, maybe even more on shoulder on tooth number 8. But I also was able to do some areas quite thin. You can see some areas of tooth number 10 are quite shallow, tooth number 7 quite shallow, but there were areas where they were a bit thicker. And when speaking with the laboratory, they said for the preparation we did, they prefer to use a high opaque ingot, not a block. This had to be done again by ingot. So if you have these dark teeth, speak with your lab, make sure that they are pressing, or they have the capability maybe to do both. But this is a case where you need somebody who presses lithium disilicate, because again, there is no high opacity block available. This is the best picture of the case for me. The outcome is the follow-up 6 years, even more But here was my favorite picture of the whole case, because on the top, we knew we had to do a crown. So no surprise there, but look at the intaglio of the other teeth. You can see that we have a 3/4 crown and on tooth number 9. We have these smaller veneers, and it didn't matter of the prep design. All it matters was preserving as much tooth structure as we can, preserving as much enamel as we can for bonding. And this to me is the best because on 3 of those 4 teeth, we were actually able to preserve the cingulum. And there's been some speculations that most of the structural integrity, or up to 70% of the structural integrity of an incisor lies within the area of the cingulum. So, is this a service for the patient? I would say I think so. Now, I did use a dual cure resin cement for veneers, and I also used a dual cure resin cement for number 8. And are there any concerns? And of course, the concern here, as we're finishing up, is that over time, one of the concerns with dual cure resin cement is because they were made with, sometimes there's a tertiary amine used to help stabilize the composite, can yellow over time and show through. And so sometimes on these older cases with very thin veneers, you'll see yellowing around the margin, or the body will get like kind of a yellowish look. And I'm not worried about this here. Why? Because I have a very highly opaque material. And so the reason I use the dual cure cement in a case like this is because I want to ensure full polymerization, because I would not be sure that there would be enough light transmittance from my curing light to the resin cement to ensure that I have full polymerization. So I'm not worried about yellow, and I'd rather just using a dual cure resin cement in such cases. And I'm not talking about the crown, but also the veneers as well. So here's the post-op. I mean, it was okay. There's some issues going on. The patient still had discoloration, but this shot of the value shows you that there is good harmony and uniformity and some gingival resolution of the restorations. So by just prepping very minimally, instead of converting everything to crowns or everything to PFMs, we were able to maintain cingulums on 3 of the 4. And I think we were able to achieve a very uniform look to the teeth. Now, here's the thing. Here's where she came in 5.5 years later, and she was still doing okay. She was quite happy. She was not great, but there's something else going on here. And so this was done by a lab who's no longer in service, and there may be a reason why. I showed this case one time on social media on one of the platforms, and I said, hey, what the heck happened here? Because if you look at tooth number 8, you can see that the glaze, it looks almost monochromatic again. I mean, it could have been done stained a little bit more, I thought initially, but you can see that there's even areas of the tooth, especially the mesial of number 10, the distal of number 9, where it looks very, very splotchy and looks very dull. And I had no idea what happened there. And this case is even older now, and she's still doing well with it. But a lab technician told me, he said, likely what your laboratory did is and I talked about the steps of fixing or treating glass ceramics. They probably pressed it. And remember, when things get pressed or milled, they come not only monolithic, but they're monochromatic. So the next step you would typically want to do is you want to place a stain, and then you heat it so that the stain takes, and then you put a glaze. Well, and for those of you who are doing this, want to do this at home, just take care, because there's also the option to do a stain glaze in a single step. And so what likely happened here is that the laboratory did a stain and glaze together, and over time, when the glaze starts to wear, you also lose the stain, and you create a kind of a sort of monochromatic or splotchy looking restoration like here. Now, I told the patient she didn't mind whatsoever. She didn't even notice. But again, she sees it from social distance, and I'm blowing it up quite large. But just please be aware, just make sure that if you see something like that, tell your laboratory, use an internal stain and then a glaze. And also for those of you who are doing it in the office, it might be best sometimes, especially in the anterior, to do a separate stain, then glaze. And so with that, folks, I do want to thank the IDIA for their time. Thank you, everyone who's spending this Saturday with us. I look forward to any questions you may have, and I'm going to put my email here if anyone likes. If you have any